Okay, are you ready for the last session? Not all are ready. I promise that you don't have to be active now, just to listen. And you may ask questions during this last session if you have some questions, okay? Now I'm going to talk a little bit about the implementation of shared decision-making in Norway. So first I want to show you a timeline. So because some ask me actually, how long have you been working on shared decision-making in Norway? A break here. And yes, we started in about 2012. And in 2014, the term samvalg was launched. That's the Norwegian term for shared decision-making. And after that, during that phase, we had a very active user and patient organizations, because they really wanted and requested more involvement in decisions. So this is one of the he was a leader of a big user, and he said, this says the patient's healthcare service. So that was like a big slogan, yeah, at that time. So they published a lot of different articles about that. And also, samvalg was included in several white papers during a really short time period. So that was helping us a lot. And also the ministry's assignment documents to the regional health authorities. So the ministry gives us, where I live, sorry, assignment papers, so what we should do the next year. And there they stated that we should, we should work with shared decision making, also develop patient decision aids. And in the ISDM society, so for researchers in shared decision making, some time now we have been publishing status reports from different countries, how the status of implementation in the different countries is going. And this was the first time in 2017. So this was our first report on how it was going. And in 2020, our health minister said that shared decision making should be the new normal. So he said that, and that was included in our, like a big white paper called the National Health and Hospital Plan. So that was a game changer actually for us working in shared decision making. And then we had a new status report. We were a bit disappointed when we wrote this one, right, Jürgen? Because when we wrote this one, we were very optimistic that it will go fast, but it didn't go so fast. So, but we made a new report here, and probably there will be another some years. So the National Health and Hospital Plan, shared decision making shall be the norm. And the Ministry of Health and Care Service also said this year that shared decision making and the possibility of using patient decision aids should facilitate participation. So we really have political support, and that has been like really a huge game changer in Norway. In the beginning this morning, we showed this picture of Norway. So here you can see the 4 health regions: the Northern Norway region, Western Norway, and then we have Southeastern Norway. That's the biggest of the health regions. We serve more than half population of Norway, and this is where I work. And I could have said something about the implementation status in all these regions, but I'm not able to do that today. But I will about how we collaborate. So we have we call it an interregional project. It's a national project, and we have a project group to coordinate the implementation of shared decision making. And we have a mandate, and it says it was developed with the Ministry of Health, and they said that we should selection criteria and prioritize which kind of decision aids we should develop within the next 5 to 10 years. So we have developed a list with criteria, such as how many patients face this decision as one criteria. Is it the user organization want this? Are the clinicians on board? Is it relevant for shared decision making? Do we have good evidence, and so on? So we have done that. Further on, they said that we should further develop the quality criteria for approval of patient decision aid, and also develop a guide how to meet these IPDAS criteria. Because a lot of you know maybe the IPDAS criteria, but it's not so easy for developing teams to actually know how can we operationalize these criteria. So that have we done now, all regions together, and be approved now by the CEOs within a few months, and then published on our national website. Additionally, we are continuously sharing experiences and to facilitate implementation. So training and a lot of different things we are sharing, can learn from each other. That's a very important point. So now I'm going to zoom in to my health region, because there I work and know most, and I'm going to give you some insights. So we in our health region have also a development plan. It goes to 2040. I know that you in Korea are also thinking what is going to happen to your health system the next 10 or 20 years, right? It's important to look ahead. And this is like an overarching strategy for how we're going to meet the healthcare service. And within this, we were able to develop an own implementation strategy for shared decision making. So that was actually a dream come true when this happened for me. So this strategy we developed, it's a Norwegian if you translate something later. It consists of evidence-based recommendations, proposals, and examples of measures to implement shared decision-making in the specialist healthcare in the region. So, and now you're wondering maybe how did we recommendations within the strategy? And we did that by summarizing international literature. So we actually have a report, 60-page report on international literature on the beneath this strategy, with the recommendations based on what do we know of which measures actually to the implementation. The goal was to strengthen the patient involvement in health decisions, of course. And we have 4 areas of focus. The first one is management, level of ambition, and organization. And I'm just going to give you some elements of each of the areas of focus. So this is in Norwegian, something is Norwegian, but I'm just going to show you how it's structured. So the level of ambition and strategy must be clarified, anchored, and owned by leaders of the organization. Because we know that we are almost not able to implement something if the leaders are not on board, right? So this is very important. To give you one example here, it says, so this assignments or measures which are within the regional health authority. So this is actually my working list. I work with all these measures to make them happen. And these are the hospitals, all our hospitals in our region. So they are supposed to develop own action plans based on implementation strategy. They should develop own action plans, how to implement shared decision making. And many of them have already. So not all hospitals are listed here. We have a few more. But we have now 4 hospitals who have developed their own action plans based on this strategy. Several others have started. So it's going actually very good. So some insight from the next area of focus, that is increase employees' SDM competencies. Here on the health region, we have further developed and continue to evaluate modules within the Ready for SDM. And you received some Ready for SDM training earlier today. So now I'm going to jump out of this presentation and give you a little more insight what this training framework is about. It's a part of a larger research initiative called the DA Factory, located in the North Norway, where Jürgen was the lead. And as you can see on the logos, they fit together. And they fit together because this is a Rubik's Cube. Do you know it? Yeah. DA Factory is development of decision aids. And this is one way of implementing shared decision making, right? But the other side is train healthcare professionals in shared decision making. So the background for this project was that we knew that healthcare professionals were lacking sufficient skills in SDM. We didn't have any evaluated training programs in Norway. And with the international programs, we also had some challenges, because when we looked at the literature, they target only single professional groups, as we talked on earlier today, right? They had a limited interprofessional approach, limited in the content. And by that I mean, when I looked at the papers, you were not able to see what are they actually doing within the SDM trainings. And few were also rigorously evaluated. So there was the need for a unified training program to address these challenges. The primary aim of this Ready for SDM project was to develop a training program for healthcare professionals. And at the start of the project, we established some principles for the development process. So we wanted it to be customized to the Norwegian healthcare, specialist healthcare, to various target groups, not only physicians, but others also, and to aim at different competencies levels and to have the interprofessional approach. Also, to ensure sustainability, we wanted to have a feedback-driven learning system so that it continues to develop and be evaluated. We wanted a stepwise development process guided by implementation research and evidence-informed and theory-driven, of course. So by adhering to these principles, the aim was to create a flexible and effective educational structure that could support long of shared decision making. So just to say something about, because we call it a meta curriculum. So what does that mean? That means that it includes multiple educational measures, such as training modules and learning. So the barrier cards here is one example of a learning material, right? You have received. It defines functions and scopes of each training module, including overlap and boundaries between them. It holds components together through a common didactic approach and through the underpinning approach. So the underpinning theoretical approach here is the map in SDM and the 6 steps that go through the whole thing. And it includes also a system for adapting and developing new components. So while one individual training module can stand alone, for physician training, it can stand alone, it's also a part of a more coherent educational strategy. And now I'm going to show you a little bit more how because it was difficult in the start of the project to explain the different modules and we had to find a way to make it easier to visualize. So that's why we developed this. So here you can see we have different target groups: medical students, nurses, SDM ambassadors, that are the trainers, and we have different communication formats, so e-learning, self-study, feedback, podcasts, and so on. And then we have different learning activities. So today you have received lectures, video case, you had group work, you also did role play, and you did some individual feedback, right? And we gave some small feedback session, not so much. And observer skills, you used also the observer skills. So we went actually through a lot of different training activities today. So this is a trainer-trainer course. Here are some other modules. So as you can see, today you have received both the basic training and you have received some parts of the decision coaching, but not the entire training. And then we also have like a very short self-assessment for clinicians. We have SDM skills in situ. We have whole trainings for interprofessional teams. there are different modules, and we aim at a stepwise competency, like a development and spiral learning, if some of you know that term. So medical students get some of this in, and when they go to specialization, they will get boosters of the education. So this is from one of our trainer courses. Here are clinicians and others who want to educate in SDM. They are training. Then they get access to an online platform where we have a lot of learning materials included. And here they can go into and see examples of these steps. We also showed earlier the Korean videos. They can download presentations. So they can download a lot of different learning materials to tailor the training to different target groups. So we tried a bit to tailor the training because we included Korean videos today, right? So when I go to an oncology, I want to use oncology resources and videos from oncology. And when I train nurses, pediatric nurses, then I would like to tailor the training to them. So this system allows for that. So here we can see the barrier cards. Here we have different patient information. We have slides-based patient information. And yeah, so this is just to give you some insight of what we have on the backside of this program. The infrastructure are actually these trainers. We have a lot of SDM trainers, so both from hospital and we have look at the bag, the nice bags. All of them have the bag. And these are not only from hospital but also from universities and colleges, because then they can go on teaching. So these two train medical students in shared decision. We have some here training. She is training in pharmacy students, bachelor and master. So to give some examples. Okay, so where are we? We have developed a lot of modules and published a lot of papers. We have the infrastructure with our instructors giving the training. But it's not, also it's a lot of work. I have to encourage them all the time. They need new researchers. They call me and say, Simone, I need a new video. You have to develop something on health literacy and shared decision making. And so it's very, very funny and rewarding. And we have the implementation. So, and that we are still, of course, working on all the time, but this is included in the national, in the regional strategy. So implication for the Ready for SDM, the basic model has been integrated into undergrad and postgrad curricula many places in Norway. And SDM ambassadors are providing this kind of training. This Ready for SDM curriculum is also referred to in the National Health and Hospital Plan. And several trust has implemented several modules in their local action plans. And as you can see here, we are using the 6-step approach, and it has been included and also implemented in really a lot in all the regions have some modules implemented in the hospital, in university colleges, and yeah. So for conclusion for this part, for the Ready for SDM, comprises multiple modules addressing various healthcare professionals. The training modules are rated acceptable and most are feasible to deliver. Based on some feasibility studies, we have made a lot of different changes, and the implementation is facilitated based on this multi-modular adaptive architecture, and also the use of the feedback-driven continuous learning system. And by that, ambassadors, they contribute to the further development. So they say something is missing, we have to adjust this, and help us further evaluate and contribute to this. However, further evaluation is required to determine if this meta curriculum and within an implementation strategy actually will improve the quality of shared decision making, because we cannot say that yet because we haven't evaluated that. But now it is included in the multifaceted implementation strategy in our health region. So some references for this, and now I'm jumping back into the implementation strategy. I will let you take the pictures finished first. If you Google my name or Jürgen, you will find all the publications, or on ResearchGate. Okay, so how does hospitals implement those modules? So this is from one of our hospitals. They are using different steps to the competence. And here they say, we discussed some about competence in the break with someone, right? And here they said they should know about shared decision making. Then they will only watch a video for some. Here it says that they should be able to explain what SDM is. Then they get a little bit more. Then they should be able to use the structure, 6 steps to SDM. So they were getting the basic course and a podcast, and then so it goes all over to could be able to own presentations. So this is how, like one example of how one of the hospital has implemented it. And we have also regional competency requirements. So it says that healthcare professionals should be able to conduct shared decision making and to take trainings, and then we can measure how many healthcare professionals actually take these courses. So, for example, this number is not totally correct anymore, but within a pretty short time after we released our digital, like an e-tutorial for doctors, 200 doctors took this e-tutorial. And remember, we are only 5 million in Norway, so you have to, for us, it's a lot. Okay, so to the next area of focus, activate patients. To give short examples, it says that we should include a standard text about shared decision making in appointment letters to patient. Do you have appointment letters here in Korea? If you have cancer and you have to go to the hospital, do you get a letter digital or paper? So now in all our appointment letters, polyclinic or not, it says that as a patient, you have the right to participate in decisions between different treatments and diagnostics. Read more about shared decision making here, and then there's a link. So all this, and that can actually, may seem as a very small thing, but it can make a huge difference if you see it in the big context, right? Because then patients maybe actually read about this and will ask for it. And also the 3 questions, many of you have heard about that. We have developed several brochures and so on. And we have very strong ambassadors. And this is from a picture from one of our hospitals. And we have a What is Important to You Day in Norway. And everybody's going with a pin that says, what is important to you? And share decision making. So, and they also have campaigns from users who are writing about it, as I said earlier. And of course, one of our measures also to ensure that the checklist, map info, is available to use in the health systems, as we have talked about earlier. So it's also included in the implementation strategy. The last area of focus is supporting systems. And what do I mean by that? I mean different structural things to make. So this could be that in the development of patient information, patient pathways, like explanation of how the pathway looks, we should clarify where shared decision making is relevant. So this is from our national patient information on the platform now. And so we are very structured going through all the patient information there. So for example, for Graves' disease, so we are going through like Graves, okay, that is SDM is indicated, and then we put in a little text about shared decision making and the 3 questions, so that patient will see read the patient information. And it was also written that we should complete a patient decision aid app in our region, and we have just started that project now. We have all the descriptions ready, so we are in the process for the decision app now in the fall. So that's going to be very, very exciting to prepare the patient to be ready for shared decision making when they meet their healthcare professional. And we have a national, like this, in structures, as I said earlier, we have a of the regional coordination of instructors and for shared decision making. And we have like a shared decision making cafe on Teams every second week. And then so interested people who are interested in shared decision making come in there, and then we have a chat about different implementation barriers, about training, it's about new research. And it really is a very nice discussion area for and support the implementation in the hospitals. Okay, to sum up, political support really created wind in the sails when we began with shared decision making in Norway. Very helpful. And I'm not saying loud that I really ran after our health minister at the airport when I saw him there 10 years ago, talking about shared decision making. So don't do that. But maturity over time actually helps and pays off. And it helps also to fight for core principles. And actually Jürgen has been a contribution there, because I'm sometimes a bit pragmatic and want to hurry off. And Jürgen sometimes slows me down and says, Simone, we have to do it right and we have to be patient. That sometimes really I have also matured over the last 10 years. And of course, sharing and collaboration is very important. And that is why it's also been so nice to share with you today and to collaborate with you. And we have also learned so much from you. So with this, show the midnight sun when we started, but I'm showing it now. So this is the Norwegian midnight sun.
This picture is taken at 12 o'clock in the night.
I think this is our last slide. Say thank you so much, and would take any questions. So, are there some questions regarding this last presentation or something earlier today? Some comments? Yes.
Okay. I think shared decision making had been spread out in Norway quite much because of your effort, I think. The first time the SDM has adapted the government thing, how could they, in the government side, how could they recognize the value of the SDM at the first time? Do you have an idea about that?
Yeah, that's a very good question, actually. And it was not because we had the evidence at that point, because we didn't have so much evidence. The health minister at that point in 2012, he actually wanted SDM because it was the right thing to do. Because it's, yes, because not because of the evidence, but because it's the ethical right thing to do, that we as healthcare professionals should not make decisions on behalf of the patient. So to him. So, but nowadays I know that we need more, like we need something else also probably, and we are still fighting for that and making new evidence. But that's actually, I really mean it. So when somebody says, why is shared decision making important? Of course it's nice to have the documented effect. Ethical point of view is the most important. So, because I'm not able to make an informed decision on behalf of somebody else.
In addition, we can say that other countries flew ahead. So Germany, the same moment that was here, Norway 2013-14 was 10 years before, 12 years before. So there were some models. I wouldn't say that they had come so far, but there was much research about shared decision-making activities and trials to implement have been a reason to import this to Norway.
Yeah, definitely,
So-
because the Norwegian government, so as many others, also look to others what they're doing, right? So our Minister of Health often goes to Denmark or Sweden or other countries and then come home with some new things. So
we used to say Norway is late on the train.
other questions or comments? Yes.
So you talked about patient decision aids earlier, and we actually made a website last year for our decision aid. To a problem, we used it as a pilot with our colleagues and some of our patients, and we realized that people find it difficult to understand on their own. So we have to use it with our patients. So it seems like you guys ran into a similar problem where you can't really trust the patient to study. So and so you're making an app now. So we're trying to make an easy mode now, or simplified, because it's hard for the patients to really do it themselves and go through all the information. So besides an app, what have you guys used to kind of make it more acceptable for the patients?
This is a big and unsolved problem, of course, because if you follow all those criteria, then the decision it will be somewhat complex. Otherwise, you would not comply with that. So really try to speak a simple language and make it feasible. The decision nurses, decision coaches are another strategy to facilitate the processing of decision aids. And I really have a hope for this app coming. If there is, if you have many decision aids working the same way and you are used to the structure, this might mean an additional simplification. Then maybe. So the 15 decision aids, they are still too complicated, and
Too much text.
And they removed the number, so they are not really good. And maybe we come further with the apps.
Yes, I think we have all over. No, because we want to meet the quality criteria, right? Yeah, I agree. Yeah. Other comments or questions? I think your heads are pretty full now, right? Yeah.
I'm really impressed how long. Yeah, I see. You are still awake.
Okay, yeah, I'm still awake, yes. Simone, you said that you are optimistic in 2017, right? But your implementation does not go that well in, I believe, 2020 or 2020, even now, right? So there should be something that you think, oh, we should have been done that, or we should have not done that. So because we learn from the mistakes and failures, right? So any mistakes and failures that we think, anyway, all the things happen in the local context, so adapt it. But I'd like to know what kind of mistakes and failures that you think, oh, it's a really major one. If you follow us, don't do that.
So I worked to be allowed and be able to make an implementation strategy for, I think, years before my leaders acknowledged that this is a good idea. So to have a good implementation strategy, and I know that you already have like much components together in your project already, it's essential. And also to work together, not competition in the country, because it destroys the project and the meaning. We are supposed to work together with shared decision making, not compete, and they do that several places in research and academia. That is no secret. And also, one of the things we were disappointed about was that we weren't able to decision aids quickly, actually, and got them implemented. And in the recent years, we have even more focused on the quality of the information. So evidence-based patient information and patient decision aids are really like, we know from evidence that's very important to have that in place. conduct and really include the patients. So
I would say we had a crisis with the people from Northern Norway, and this was about competition and things like that. And I think we have lost about 5 years because of that. We can say we would have further. Otherwise, I can say Norway, the way we go in Norway is a dream. In Germany, it's much more difficult. You have so many more parties involved. It's so difficult to come to an agreement. In Norway, it's quite a good idea, and you have some good arguments. You come through. It's really possible. So this is not slow going, but we could even have been faster without those unnecessary conflicts.
we have the implementation strategy. There are developing local action plans, and we are like nationally and in our region, we are really like working with the different measures in the implementation strategy. And so the aim is, because we don't think that this kind of training will change the whole culture, right? But the aim is that the different measures within the implementation strategy, that this as a whole will actually then change the communication between this doctor or nurse and patient.
It's also an important point, because you could also think that you need strong and very measures, also interventions, maybe a training that really change the communication very much. And I would like to have such, but I'm not sure. We actually want another strategy. All those modules, I'm clear over that they're not changing the world. They are not really. Such a module alone will not make you a much better communicator, but we try to change the culture. This is but it's a decision to make what you want. Of course, or what you prioritize. It's not exclusive, of course.
And at one point, our CEO said that we have to prioritize training instead of decision aids. So that's why we have gone further with the training than decision aids. But now we are also more decision aids. So, so then it could look like that you get a diagnosis, you get a text message through a good quality patient information or a decision aid. You go into that, you read before you meet the doctor, you're prepared. You go into the hospital and there you see the SDM movie, you see you maybe visit a nurse, and then you go for your 5-minute consultation with your doctor to make the final decision, because you are prepared, right? You have discussed with your relatives, and then you go out and you follow up. And so like by implementing these different measures, that is the hope. Yeah.
I think the information quality is really a barrier we need to overcome soon.
And the attitudes of us healthcare professionals, of course, and patients. Okay.
Other questions or discussion points, feedback?
Then maybe we should let you fill out your questionnaires.
We are very grateful for this day.
Yeah,
really. I learned a lot. I saw you working. I saw in your eyes you were interested. Really, I'm really fascinated. Thank you.
And if you have any further questions later on, you can just email us, attach on LinkedIn or whatever. And Professor, you also have our contact information, of course, so just contact anyone in the team. Okay.